Professor Andreas Kremer, how are
Thank you very much. I'm doing fine on this Friday afternoon.
you? So, do you prefer professor? Do you prefer doctor? Are you going to go German and go professor, doctor, doctor, professor? How do
I
you feel
I'm
today?
happy if you call me Andreas. That's all right.
Okay, so thank you so much for joining us. I'm looking forward to this. I've not worked for you in ages, so this will be good fun. So, as it's Andreas and I, we need to set a few ground rules. No biting, no pulling hair. No. So today to be um, answering your questions. We're going to do it in the best way we can, but it's going to involve general medical information and it's not going to involve any specific medical advice. The conversation that Andreas and I will have today is not going to take the place of your appointment with your consultant, but what we hope to do is empower you and give you more confidence and knowledge in the time that you do have your own conversation with your consultant, that you'll be in a better place to have that conversation. So that's the aim for today. And let's address the elephant in the room. I'm just going to say three initials, Andreas. O-C-A. How are you? Where are you?
Well, I mean, obeticholic acid is the first in-label second-line therapy. As you know, it received a conditional approval in 2016 with the prerequisite to perform a confirmatory study. This confirmatory study was performed, however, in a setting which made it unable to perform a long-term placebo-controlled trial in a situation where you could receive the in-label drug already by a regular pharmacy. And as it turned out, this trial was negative due to various reasons. We are aware that it would be unethical to keep patients for many years in such a trial, just, you know, controlling lab values and treating complications. On the other hand, many patients in the placebo arm received second-line therapies, additional off-label therapies, and there were maybe also some patients which had a very advanced disease stage, which should have not been treated anymore. The recommendation of EMA was to retract the conditional approval, and this recommendation was now accepted by the European Commission, but we just received yesterday the information that they redraw from this retraction due to several interventions and ongoing discussions on many layers of politics and patient organizations, doctors, and so on. And so it's an ongoing story. We don't know in the end how this will turn out to be in the future. For the time being, I think we are happy that for what we know today, that we can continue the treatment for the time being, but I don't have, the glass bowl or glass, where I can look into the future and see how this in the end will be then for our patients. Overall, this is of course a big damage to rare liver diseases, to the patients with PBC in particular, but also for the development of future therapies. This is a big hurdle because all future drugs will have a comparable situation in regards to confirmatory studies and so on.
Yeah. Okay. Is there a single expert, PBC expert, who actually thinks that OCA should come off market?
Well, you know that there are some voices which are negative about that. I think we have solid data that it is a quite safe drug if you use it in the right patient population. So if you exclude the very advanced cirrhotic patients, decompensated ones, maybe portal hypertension and so on, which anyway are a absolute minority of our whole PBC population, to be honest.
Indeed.
Symptom burden is the second point which needs to be discussed. I think there are a very few patients where this is indeed a problem, where you know, the patient or we as treating physicians are unable to control pruritus, but it's again a very small percentage in my point of view, and there are way more patients where the drug has been stopped to pruritus where the physicians were not eager to tackle that problem and treat pruritus first, or to perform a drug holiday and restart at, you know, lower dosage, lower intervals, and so on. I think from the real life experience, it's quite safe. We have clear-cut data that does not only improve surrogate markers, but also likely hard clinical endpoints if we do comparison with real-world data, registries, and so on. So I personally think all those patients who are on ursodeoxycholic acid should be ensured that if they are not in a very advanced cirrhosis stage, and if they do not have a significant pruritus as a symptom burden, they have a safe drug, which exerts strong anti-inflammatory properties and also, of course, anti-cholestatic properties. It's likely also to exert anti-fibrotic properties. In the end, the final goal to improve fibrosis in our patients. That's, you know, the primary endpoint in all MESL-D, so the so-called fatty liver disease trials, where we want to improve fibrosis. In the end, of course, we would love to have a drug which also improves fibrosis in PBC. There is preliminary data supporting that. And so I think if it's well tolerated, it should be continued. And the vast majority of PBC experts would argue the same way as we now just discussed it together.
Okay, perfect. That's helpful. Thank you. So just to recap, if you just tuned in, we've had bad news and good news all at once this week with OCA, but as it stands, the license is still current and we are awaiting further developments. So thank you for that detailed explanation, Andreas. I do have to clarify that this is not a personal question. However, the question we have in front of us is, can we have cannabis? So I'm assuming that somebody with PBC is asking, if they have PBC, is there any risk from taking cannabis? I guess is as close as the question can be.
Sorry, what is it about?
Cannabis.
Cannabis. Oh, sorry. Yeah. Okay. Yeah. I mean, we can take cannabis on various ways. You know, we can smoke it. We can take it as you know, a tea, or we can use extracts. So that would be the first question: how it should be, you know, consumed. We know that patients with severe pruritus, which is otherwise intractable, can have significant improvement of pruritus. It's also used for pain treatment. I think per se, if it's smoked, it's not improving overall health. I think we are aware of that. Whether this has a very significant impact on PBC, we have no data, but smoking per se worsens fibrosis or formation towards cirrhosis. So in principle, smoking has a negative impact on hepatobiliary diseases. In that regard, I would argue not to smoke with an existing liver disease, and that would also hold true for cannabis. So cannabis extracts for symptom burden is okay, and that can be very efficacious if other treatments are not, efficacious in treating pain and or itch.
Yep. Okay, perfect. Thank you. Here's a question. I received my Urso medication today, and it says that I have to take it at 8 a.m. and 8 p.m. Would it be okay to take it at 7 a.m. and 7 p.m.? And on the days I do intermittent fasting, can I take a dose at 11 a.m. when I break the fast and then at 7 p.m. in the evening? So that's a very specific question.
Yeah.
I would love for you to talk a little more about Urso dosing in general.
Yeah. So I think if we talk about a bile acid, we have to imagine that bile acids undergo the enterohepatic cycle. That means they are taken up in the end of the terminal ileum, transported to the liver, then conjugated in the liver. So Urso is conjugated with glycine and taurine, and then they are secreted via the bile into the gut lumen again. And this circulation is taking place several times every single day. Now, when we treat patients with Urso, we change the bile acid pool from a human hydrophobic bile acid pool towards a more hydrophilic UDCA predominant bile acid pool. And for an optimal homogenization of this bile acid pool, we recommend to take initially Urso in the morning and Urso in the evening, that this homogenation of this recirculating pool is taking place in an ideal and fastest approach. What we normally tell our patients that after 3 months this is a homogenized pool, and whether you take the whole dose in the morning, the whole dose at lunch, or the whole dose in the evening, doesn't matter if you take the dose. So if you do intermittent fasting, you can just decide that you always take it in the evening, or you decide to always take it in the morning. That doesn't matter. Even if you do fasting, you can take it with a glass of water. That is, in my point of view, it's not necessary after 3 months of treatment to separate the dosages, and you're very flexible with taking this medication. So no impact on time changes whatsoever.
All right, perfect. Helpful. Thank you. Similar question, but totally different. I have PBC and diabetes and would like to take apple cider vinegar to hopefully reduce my blood sugars. Will the apple cider vinegar affect my Urso?
I don't think that it will affect Urso. I mean, apple cider vinegar is, suggested to have, beneficial effects on, metabolism, on, digestion, and maybe also fat burning. And it is suggested also to be beneficial if you have diabetes, by increasing insulin sensitivity. Now, I don't see any potential for interaction, despite the fact that both substances end on the term acid. Vinegar is an acid, ursodeoxycholic acid is also an acid, but that is not harmful. There is no interaction. So yes, you can do that, but be aware that diabetes mellitus is controlled by a long-term glycated hemoglobin, a so-called HbA1c value in the bloodstream, where you can control for the efficacy of anti-diabetic treatments. And if this values goes up or is too high, then diabetes treatment should be optimized. And in these cases, maybe the apple cider vinegar is not sufficient.
Okay, perfect. Thank you. Is there a special diet for PBC?
No, except for limiting alcohol consumption. So in principle, I tell always my patient, if they ask me what kind of diet should they take, I always say, please don't do any diet you cannot, persist on until the end of your life. Because diets are only efficient and working if you do them until the rest of your life. And everything else is rather, causing yo-yo effects. You change temporarily your metabolism and, whatever. I don't think this is helpful. Intermittent fasting is the best way of any diet if you want to lose weight, in my point of view. I always say alcohol is a no-go the more the liver disease is advanced. If you are an advanced fibrotic or a cirrhotic patient, then I always tell my patient 0 alcohol. That means really 0. All earlier stages, if this is once in a while an alcohol, I'm not against it. We still have to live our life, and so if once in a while a glass wine, champagne, or whatever, a beer is belonging to that life, I think we should not be too strict on that. I always tell my patients, if they want to do something good for the liver, it's good to, reduce weight if they are overweight. And in that regard, I always tell my patients, eat fruit, but don't drink fruit. So eat 2-3 fruits per day, but not more. And don't take any smoothies or juices because they contain a lot of fructose. And fructose, if it's, coming in high amounts to the liver, the metabolism cannot be upregulated, and that activates a fatty acid synthesis in the hepatocytes, and this causes fat accumulation in the liver, and this is bad if there is already a pre-existing liver disease such as PBC, but of course this also holds true for all other diseases. So these are in principle my recommendations to my patients, but otherwise I always say the Mediterranean diet, if you modulate, if you're not, too homogeneous on your diet, if you eat some day this, some day that, and Mediterranean diet, I always say this is not pizza. So every day 2 pizza and pasta, this is not the Mediterranean diet, but you know what I mean. The typical Southern European diet, I think, is healthy. So that would be my recommendation. If they want to have anything fiber rich, lot of vegetables, meat is fine, fish is fine, all kind of, milk products, everything, that is all wonderful, and just I'm not very strict on the diet, to be honest.
Okay, perfect. Thank you. UTIs and PBC, so a urinary tract infection.
Yes.
Any advice, information?
I mean, we know that in PBC patients, we see urinary tract infections somewhat more often compared to the normal healthy population. Urinary tract infections, if they are clinically meaningful, should be treated with antibiotics. There are some antibiotics which can be used as a single dose, for example. I think if that is repetitively a problem, it should certainly be checked which kind of bacteria are causing the problem. Do I address that adequately? If I take an antibiotic, are there any problems with the urine flow. So are there any stenosis? Is there any reason why maybe the urine flow is diminished, and that's why you have an bacterial infection? And then, of course, it's always the question, how can I avoid that or reduce the frequency? There is only limited data on that. I always tell my patients, you feel that. Patients feel that typically when it's just to start such an infection. You get polykysuria, you have to go repetitively times on the toilet, despite you only pee a very small amount, you have burning pain and so on. So if you have the very starting point, I say always you can use ascorbic acid, so vitamin C in high dosages. You just put that into your drink. I would say a couple of grams, 5-6 grams, over the day. This makes your urine very acid because vitamin C is directly excreted if it's not needed. And these high doses directly go into urine. You acidify the urine, and bacteria don't like that so much if the pH is too low. So this can be used to overcome a very initial phase, maybe. If that is not possible, I like the novel treatment approach of D-mannose. This is a special sugar which is not metabolized in the human body, and there is clinical trial data indicating that if you take that early enough, you can also treat a urinary tract infection with such a mannose treatment. And on a low dose basis, on a continuous treatment, you reduce the number of new or concurrent UTIs in the follow-up period. And this is not an antibiotic, it's just an osmotic modulation. So the sugar goes into the urine, and that drives, the urine flow. The bacteria don't like that if the osmotic pressure is altered. So these are, let's say, somewhat natural ways of overcoming these infections once you have them several times a year. That would be my recommendation. Otherwise, if it's severe, if it's associated with real clinical symptoms, fever, and so on, you have to go to your physician and receive an antibiotic treatment, because these urinary tract infections can climb up to the kidney and then cause way more severe infections, which should be avoided.
Perfect. All right, thank you. HRT and PBC. What can you tell us?
Sorry,
You're not the easy ones today.
I didn't. What was the combination? PBC and
HRT, which I think is hormone replacement therapy.
Yeah, right. Yeah, I always, there's always the fear that hormone replacement therapy, hormone replacement therapy is something like if you would tell me I buy a car, and then I would ask you, yes, but what kind of car do you, or let's say vehicle or so, it's a Fiat or a Porsche. There are many ways of replacement, and it could be more on the estrogen basis, can be more on the progesterone basis, and combinations. So it's very difficult to be very general in this situation. But if it's a low dose treatment, which is commonly used in these patients, I would check lab values for that. I'm very liberal in the treatment because, symptom burden in mid-aged women can be dramatically improved by such a hormonal replacement therapy. And if lab values are not affected, in particular the cholestatic pattern in our PBC patients, I always agree on such a treatment. So in principle, whether it's oral contraceptives or hormone replacement therapy, as long as lab values are not worsening, I have no limitations to these treatments. But this should, of course, be controlled for.
Okay, perfect. Thank you. And there's lots of kind of PBC and milk thistle,
And
which I
milk,
think is also called silymarin or something.
silymarin. Yeah. I think silymarin is one of the most commonly used additional treatments in liver disease. There is really extremely limited data on benefits in chronic liver disease, but somehow it established itself to such an extent that many patients uses it. If a patient tells me I have a better feeling, my quality of life is improved, then I say continue the treatment. Otherwise, I always say the only one who has a significant benefit is the company producing it.
Okay, all right. Duly noted. I'm going to interrupt the questions just to let you know that you are currently live in Australia. You're
That's
currently
good.
live in the UK, and you're currently live in the US that we know of. And there's lots of people commenting on Facebook that they are on the way to the PBC conference. So if you are on the way to the PBC conference, travel safe, and we will see you very, very shortly. Now, we have lots and lots of questions about cholesterol and PBC. People are asking about their HDL, they're asking about their LDL. Now, somebody's talking about cholesterol of 135 and somebody's talking about cholesterol of 6.2. So I know there are two different measurement units. So can you just talk a little about cholesterol and PBC, please? And maybe cover the HDL, the LDL, the lipoprotein X, and just explain to us, please, if you could.
Of course. We commonly observe a hypercholesterolemia in our PBC patients. I think this is very important to know. The issue with the hypercholesterolemia in PBC is that typically the LDL fraction is increased, and patients have learned LDL is the bad cholesterol. And indeed, this is true, but there is one but, namely that in PBC patients, we have a special lipoprotein, the so-called lipoprotein X, as you mentioned, Robert, which runs within this LDL fraction, and we cannot distinguish LPX from LDL by regular routine measurements. We can only, differentiate that once we determine so-called apolipoproteins. These are proteins which are associated with the lipids and form, complex molecules. And these apolipoproteins are only in LDL and not in the lipoprotein X. Lipoprotein X is formed by hyophilic substances, lipids, and they are not atherogenic, meaning they are not associated with an increased risk for cardiovascular disease, myocardial infarction, apoplexy, stroke. So in that regard, you should be aware that purely looking at LDL doesn't tell you anything, because you don't know what is really LDL and what is the PBC associated lipoprotein X.
Okay.
So if we think about treating an increased LDL, I always tell my patients, look, we will only treat it if we have additional risk factors for cardiovascular diseases. And this is diabetes, this is arterial hypertension, this is a familial risk. So if the father, the mother has had a myocardial infarction, particularly if that was in younger ages, and other factors. So smoking, for example, and so on. So if these additional factors are not present, I don't treat this hypercholesterolemia, to be honest. If an additional factor is there, then I would treat it as I would treat hypercholesterolemia in every patient without PBC with a cardiovascular risk. And that means we try to reduce it. So if the patient only has a risk factor, the treatment aim is different compared to a patient who has had already a myocardial infarction in the past. So that depends then a little bit. Statins are, of course, the backbone of lipid or hyperlipoproteinemia treatment. If they are not well tolerated, there are alternative treatments, ezetimibe, for example, and more modern approaches are existing to reduce LDL, but keep in mind only if indicated, we would perform such treatments. If you are, and this is, I have to state that we use fibrates in our patients. So fibrates are actually previously developed to reduce triglycerides.
Yeah.
However, if we have a statin and a fibrate, the risk for myalgia and rhabdomyolysis is significantly increased. So this should be really discussed between, the different disciplines. If there is indeed a need to treat with a statin, and if there is a need to treat PBC, for example, with a fibrate, because there is no good alternative in such a patient. So this should be done with caution. I think the more modern PPARs, which are on the horizon, have less risk of interactions with the older fibrates, but this should be kept in mind. And HDL is the good cholesterol, if you want so. So this mobilizes cholesterol in the periphery and brings it back to the liver. So if that is increased, that's rather good. And actually, we currently always look at the ratio LDL to HDL ratio. And if that is above 3 roughly, then this is also a sign for an indication for treatment.
Okay, perfect. That's helpful. Okay, so I've to add Italy and Canada to the mix. They are both watching as well. So welcome, buongiorno, bonjour. Right, we've got a question from somebody in the room. I'm not going to mention your name. So my question to your question is, you say you're diagnosed. Are you on therapy? Is my question for you. And what we'll do is we'll come back to that question very, very shortly. PBC and AIH. Does it shorten lifespan?
Well, this is if a patient asks me how long will I live, I always say that's not me who decides. Nobody knows.
That's ever said that.
So I would earn my money in an easier way if I could look into the future. So but to be honest, so PBC and autoimmune hepatitis can occur in the same liver or the same patient. And we have to keep in mind that this, previously overlap syndrome or now invariant syndrome entitled disease is not very common. I think it's more commonly diagnosed than it is really existing. I often think that patients with a difficult to treat PBC may be misdiagnosed, at least to some extent. And in these cases, I always question whether immunosuppressants are really helpful on the long run. But this is very difficult and I think requires really an expert hepatologist. So everybody who has such a diagnosis should really be seen by an expert hepatologist who has a long-lasting experience with that, because long-term immunosuppressive treatment in a situation where the cause is PBC and not autoimmune hepatitis is not an ideal treatment approach. Now, let's discuss prognosis in such a situation. And let's presume it's indeed there, so autoimmune hepatitis is there and PBC, then you need UDCA treatment for the PBC and you need an immunosuppressant treatment for the autoimmune hepatitis. And both drugs have to be taken lifelong. However, if you do not have a very advanced disease stage, liver cirrhosis, advanced fibrosis, and you have a good treatment response, then I wouldn't think that your lifespan is reduced. Because we know that from autoimmune hepatitis patients as well, if we treat them adequately, and if the disease is not progressing because we use lifelong low-dose immunosuppressant, then there is no limitation in the lifespan due to the underlying liver disease. I think this is very important to state. And I have patients who completely normalized under such a combined therapy. And so I would expect that these patients have no limitation in regard to the life expectancy. In particular, if we talk about normalized liver enzyme pattern.
Okay, perfect. Thank you. COVID. So we've had a patient who's written to us. They had COVID recently, which caused a lot of bone pain. And they're wondering if COVID can increase your ALP.
I mean, you know, every infection can cause increased liver values or liver function tests. Transaminases are more commonly going up, but we have also seen that in patients with PBC and PSC, once they have infections, and that means infections outside the liver, so not a cholangitis, but let's say a pneumonia, COVID, viral infection, whatever it is, these liver values may go up, and if they come back after the infection is adequately treated or is gone, then there is no need to change any regimen. If they persist on a higher level, then I would re-challenge the underlying treatment and check whether additional therapies may be required.
Okay, perfect. Helpful. Thank you. Next question. Are L-arginine and nattokinase supplements safe to take?
Well, you know, these so-called over-the-counter products are undergoing way different controls and safety aspects than a regular drug. So if you go to Dr. Google or whatever in the internet on any kind of these pages or buy it somewhere in a store, you have to be aware that there is no safety requirements for these products. So the law typically says the company who produces these things is not required to show safety data. And secondly, and that's, I don't know for the UK market, but for the German market, I can tell you that the prerequisite is that 50% have to be inside what is written outside of such a bottle. That means that you have no idea about safety and you don't even know what is inside the pill you're just swallowing. So that's one reason why I'm very reluctant in saying anything about safety, because it's very difficult to estimate the real risk of these things. There's millions of these compounds and tremendous amounts are consumed, billions of US dollars, pounds, euros are spent by the thought it could strengthen whatever. I always tell my patients they should rather save the money for something else, something more enjoyable in life than that. There is no evidence that this is improving the underlying liver disease. So that I'm rather on the reserved side of these over-the-counter products.
No, I get that. I understand, and thank you. I'm delighted that you are. We've got a couple of questions that are very, very similar, so I'm just going to ask you as simply as I can. We've had a couple of people that have had an unusually high FibroScan result, and they've had subsequent biopsies which seem to confirm PBC, but not too much fibrosis and certainly no cirrhosis. What do we think could explain the high FibroScan readings?
Well, I mean, I think the audience should be aware that FibroScan is measuring stiffness, and the stiffness of the liver is not per se only due to liver fibrosis or scar tissue in the liver. There are many other factors. It is purely sufficient to have had a good meal, a good breakfast, and then go to the FibroScan measurement, and it can be doubled the value. So purely by the increased portal vein flow, because we have a lot of good nutrients now coming from the gut, which are transported to the liver, results potentially in a significant increase in liver stiffness. The same holds true if the blood flow is not adequately going out of the liver. So if you have some problems with your heart and some of the blood is, there is some stasis in the liver veins, it's not very good transported out. That also results in very high elastography measurements without any signs of fibrosis. Thirdly, if we have liver inflammation, so if we have some kind of inflammatory component in the liver, which may be purely due to PBC, that can also increase significantly elastography, but that does not mean that there is a need for fibrosis or scar tissue. So just to give you a couple of examples how this can be influenced. And so I would be very cautious to argue I have an increased FibroScan, and this is then per se then an advanced liver fibrosis or cirrhosis, and therefore a liver biopsy is typically performed to confirm or exclude that. And then we have to, of course, think what is then the cause for the increased elastography. And a single increased elastography, I would just repeat. And if it's confirmed, then that would be for me a reason to look for other causes. And keep in mind, it's good to look at that. I think it's very important to perform the elastography, and very happy that it is done more and more routinely. But it should be ideally always done in a fasted state, ideally, at the same time of the day, ideally by the same machine, not by different machines, and ideally by the same examiner. So already, differences in the handling procedure can cause or result in different values. So it's a nice way of non-invasively looking at the liver, how stiff the liver is, but with the named limitations.
Okay, perfect.
So say yes, it's possible to have a significantly increased stiffness measurement, but not advanced fibrosis or cirrhosis. This is very well possible.
Okay, that's ideal. And one of the things that we're doing, so we're actually having a fully qualified nurse at the conference who's going to be doing FibroScans. And she has urged patients directly, because they're booking appointments, not to book their appointments after breakfast or just after lunch, and to make sure they fasted and that kind of thing. So that's all good to know.
Perfect.
Bit of a loaded question, but we'll see where you go with it. When URSO is declared as working, Does that mean that the blood work returns to the normal range, or it's close to normal, but not perfect?
Yeah, that's a very good question, because if you would ask 10 gastroenterologists or hepatologists, you most likely would get at least 5 different interpretations on the treatment response. And so I always, if I give talks these days, I always tell my colleagues I have a 3 column categorization. And the ideal or optimal treatment approach is certainly normalization, and normalization in particular of the alkaline phosphatase and bilirubin. If these 2 parameters are normal, I think you're on a quite safe side. Then the risk for disease progression is very low. If you have a mild elevation, and what is then mild? We currently determine that as upper limit of normal to 1.5 times upper limit of normal of the alkaline phosphatase. Then previously we would have said this is an adequate response, this is good, this is sufficient. But we know these days that there are still patients who have a moderate risk for disease progression. And who is that? These are younger patients. I would currently say patients below 60 years of age, and or those with signs of advanced liver fibrosis. And therefore the elastography measurement is helpful, so that we do not have to take a biopsy every time we perform a control. We can do the elastography on an annual basis, for example, and then see if values are above 10 kilopascal. That would be, for me, an indication that we should increase treatment intensity. And same would hold true if we have a continuously rising elastography over the years. Then I would also consider that, in particular in younger patients, as an unmet need. So there should be an intensification of the treatment of the underlying disease. If
Okay, perfect.
lab values are higher, above 1.5 upper limit of normal of the alkaline phosphatase, or abnormal bilirubin, we have to exclude, of course, the Moylan-Gracht's syndrome patients where unconjugated bilirubin is increased. But if that is excluded, then these are the 2 parameters which clearly identify patients at the highest risk for disease progression.
All right, perfect. That's helpful. Okay, so Dee wrote to us in Click Meeting, and then she's kind of put more detail on Facebook for her. So she's asking about the fact that she was diagnosed 2019, did a liver biopsy back in the day, which was very American, but let's not talk about that. Since then, the doctor has only ever done blood tests and not anything else. Now, for context, ALK-Phos is 117, AST is 27, ALT 26. So, I guess in those circumstances, would it be normal just to operate on blood tests, or should other tests be taken as well?
Well, as stated, Robert, I think a bilirubin should always be measured as well. I think transaminases, which are normal, and an AP, which is depending a little bit on the cutoff of the lab, but it's roughly around the normal value. At least if I look at our lab values, that would be roughly around the upper limit of normal. This is a good treatment response. I would always perform liver elastography and sonography once a year in all of my PBC patients, just to, control for morphology. You get so much additional information you do not get by purely measuring blood test. That is my current approach. We additionally look for bone mineralization, and depending on the results, we repeat that after a couple of years. We look for vitamin D levels in our patients and supplement that. We ask the symptom burden, fatigue, pruritus, Zika syndrome. We try to optimize symptom burden. So we do a lot in our patients aside purely looking at the lab values. So I think treatment response on ERSO is at first sight sufficient and good, but these additional aspects should be addressed. Also, thyroid gland, so TSH, thyroid stimulating hormone, is taken once annually because it's the most common additional immune-mediated disease we observe in PBC, aside, maybe the Zika syndrome and or Sjögren syndrome in our patients.
Yeah, perfect. Okay, helpful. If I understand the question correctly, I'm on HRT. I'm on URSO of 1 gram a day, and they're asking about taking testosterone. Now, this is a lady. So can you take testosterone going through the perimenopause if you've got PBC?
Well, I'm not a gynecologist, but
Okay.
testosterone treatment is, in my understanding, not a suitable hormone replacement in a postmenopausal women situation. Testosterone is used for building up muscles, but not for replacing female hormones. And on top of that, there is very little data on testosterone treatment in liver disease patients. So I would be rather cautious if we really talk about testosterone supplementation.
Yeah. Okay. Perfect. Thank you. Is there a reason why my MPV blood tests are always low? I don't know what MPV blood tests are.
I think if I remember correctly, this means mean platelet volume.
Of course,
this is the size of the platelets.
Yeah.
And to be honest, I never really. I mean, it's automatically determined, but I discard this value. I never really take particular attention on that. It can be associated with disorders from the hematological side. I think, it can be a sign of inflammation or rapid platelet release, that those platelets that are released are smaller in size. In certain kinds of, hematological disorders, this is altered. But if everything else is fine, if the total count is normal, I wouldn't draw too much attention on these automatic analyses. They are done by a machine, not by looking visually really on these cells.
Okay, perfect. Once upon a time, there was a study that mentioned hair dye and varnish, nail varnish, and a PBC. Is hair dye something to avoid?
Yeah, well, I think at that publication, I thought it was a quite intriguing animal investigation where noninoic acid or so, if I remember correctly, was as a chemical substance applied to mice. And then these mice developed, let's say, very early disease stages of PBC or something like PBC with antimitochondrial antibodies. And that drove a little bit this, situation where, people believe that toxic substances may also trigger PBC. This is data which has not been substantialized by other groups, to be honest. We have no clue how PBC is really, what is the onset? Is this maybe a toxin? Is it a bacteria or viral infection or something more on a genetic basis? I think it's multiple factors which come together. I don't see, a real need not to dye the hair. And I think if you have PBC already, I don't think that such an external treatment will really trigger the disease. So it's an interesting hypothesis on the pathophysiology of PBC, but it's very preliminary to say the least.
Okay, perfect. Thank you. We've got somebody who's been on the PBC, they've had cirrhosis, didn't respond to URSO, but they've responded to triple therapy of URSO, BESA, and OCA. Bloods have started to improve, but they don't feel any different, and fatigue is still debilitating. So the question is, does this mean my PBC progression might be slower now? And what can we talk about biochemistry versus symptoms and the fact that they, just what can you tell us about that? And now obviously the fact that she has now biochemically responded to that triple therapy and what that means, please.
Yeah, of course, the lower the labs, the better it is for the underlying disease. And whether this is reached by mono, dual, or triple therapy doesn't matter so much. So if the best treatment response is achieved with a triple therapy, this is fine in my point of view. The problem with symptom burden is that symptom burden is irrespective of the disease stage and unfortunately also irrespective of the treatment response. So fatigue in particular has, except for a clinical trial and a post hoc analysis, but in principle, all existing drugs in label and off label have not convincingly shown to improve fatigue. So we have to be aware that fatigue is a typical symptom in PBC, and it may even persist after a liver transplantation to some extent. So even if liver function is totally normal again, there is a significant risk that at least some fatigue stage may remain, if not all of the fatigue. And so this clearly illustrates us that it's more complex. And in that regard, I think treat the underlying disease as good as possible. If a triple therapy is needed, if it's well tolerated, I would continue that. But symptom burden, pruritus can be improved by treatments, but fatigue is difficult. We should exclude factors that may worsen fatigue or may cause fatigue. This is hypothyroidism, so look for the thyroid gland function. This is cardiac function, so check for that. Check for other inflammatory processes, autoimmune hepatitis overlap, other inflammatory processes which may, be or occur aside the current PBC diagnosis, depression, night itch. So if itch at night is a problem, if in principle sleep interference also outside the itch, any sleep interference, whatever it is. So sleep hygiene is important. Try to, still regularly perform sports activities, no extreme stuff, but regular movements is very important. But we are aware that we have very limited treatment options or optimization approaches in our patients if all the other factors are excluded.
Absolutely. The good news is, just because doctors can't fix it, doesn't mean it's not fixable. So if you're coming to the conference this weekend, we are going to talk about self-care, emotional, psychological, physical, and we're going to look at all the ways in which you can manage and handle your fatigue and improve it. So if you want to be part of that, it's not too late. to join on. So I've just seen the time, so I apologize for overrunning, Andreas. I've just had one more question, which is a follow-up, and I'd love to ask you that if I may. Just very, very quickly. You spoke about fibrates, and you talked about kidney toxicity and liver toxicity in some patients. So there's somebody who's come off fibrates because of kidney toxicity.
Mm-hmm.
And they're wondering what is the risk factor of going on either, say, elafibranor or seladelpar. Do they have the same risk profiles?
Yeah, that's a very good question. The major issue here is that patients with any underlying chronic kidney disease issues were not allowed to participate in the clinical trials of the new drugs due to this known problem. The question is it real kidney toxicity, or is it some kind of creatinine increase under fibrate therapy? I think this warrants a dedicated workup to really figure out if there is a persistence in increased values for the kidney function. Then I think it depends a little bit on what kind of cause we really have. There are many causes in kidney disease for abnormal kidney function, and so it's very difficult to argue purely from a little bit of an increased kidney function test to argue you can try the novel drug without any issue here. This wants a dedicated workup, and I think it would be worthwhile to contact a nephrologist to exclude any other cause which may just coexist, let's say, just independent of PBC and or the fibrate treatment. So this would be my recommendation. And yes, there are patients, I think, in the clinical trial of the novel PPARs that have had previously bezafibrate or fenofibrate, and then they were stopped for whatever reason. I don't know what, but we have not really seen kidney issues in these phase 3 studies. So potentially, with all the dose finding studies which have been done beforehand, where the companies had looked which is the lowest dose which is necessary to come to the same aim. And so in that regard, I think we know way more for these novel drugs than for the fibrates in that regard. And to keep that in mind, the first seladelpar trials, for example, they had used 20-fold higher dosages. And obviously with 1/20th, 10 milligram rather than 200 milligram, they achieved a tremendous benefit. So we don't know what is the minimal efficacy dose for bezafibrate, for example. But this underlines that we are on a safer side with these novel, more modern PPARs, just due to the lack of data from these older fibrates in our patients.
Perfect. Andreas Kremer, thank you so much. I apologize that we overrun. That's entirely my fault. If we haven't asked your question today, it will be added to the list and we will get to it on our next Q&A. Meantime, Andreas, have a wonderful weekend. Whatever you're doing, it won't be as much fun as we'll be having at the conference.
Yes.
But it's been an absolute pleasure seeing you again today, and thank you so much.
But I've been with you, Robert. I know that you organize fantastic meetings, and I wish you a wonderful weekend and a very, very successful PBC meeting. All the best, and see you very soon again.
Wonderful. All right. Thank you, sir. You take good care.
Thank you. Take care. Bye-bye.
Okay, guys, just like to thank you for joining us today. I hope we got through to your questions. There are some we've not answered yet, and we will get them, as I say, in the next Q&A, so join us for that. All the very best. If you're coming to the conference, be safe, and we will see you there. If you want to join the conference online, you can register, download the app, and then it's not the PBC app, it's a different app, but you'll be able to see the videos live streaming, you'll be able to ask questions, etc., etc. So it's not too late to join us. Take care. Keep safe. Bye for now.